This program is a presentation of UCTV for educational and non-commercial use only.
It's my pleasure to introduce our next speaker, Mr. Quint Studer. Quint is one of our nation's leading healthcare change agents and thought leaders. And if you are the leader or any member of a healthcare organization and you want to enhance service, improve quality, increase employee and patient satisfaction, and grow your business and improve your bottom line results, Quint is your man. Increasingly, they call him for advice how to do those things individually and, of course, collectively, which is the real challenge. Before founding the Studer Group, Quint spent nearly 20 years inside healthcare, beginning in a staff position and later becoming the chief operating officer at Holy Cross Hospital in Chicago and president of the Baptist Hospital in Pensacola, Florida, where the hospital was awarded the Quality Cup by USA Today and Rochester Institute of Technology, and later, I believe, even a more prestigious prize at Baptist that Quint may refer to. And then he led both organizations to the top 1% in employee and patient satisfaction compared to hospitals nationwide. He has coached more than 400 hospitals and health systems on the journey to becoming world-class leaders in their field. The Studer Group clients span the nation and include every type of healthcare organization: for-profit, not-for-profit, large, small, rural, urban, those that have great reputations and those that are trying to get the great reputations. And they include several recipients of the prestigious Malcolm Baldrige National Quality Award. Please join me in welcoming Quint Studer.
So my goal over the next hour is to take complexity and make it simple, because that way we can better execute it. In fact, I will tell you, most evaluation systems in healthcare don't work, because most of them are based on competency-based evaluation system, where you can be very competent but still not get results. So today, before you leave, I'm going to show you what I consider a better way to evaluate leadership in healthcare. I think it's a great time to be a leader. I would agree 100%. Well, you know, it's sort of like 4 or 5 years ago being a realtor. 4 or 5 years ago being a realtor, you could be pretty successful being a realtor. Today, only the best realtors are surviving. In times like this, it gets rid of the pretenders, and it really creates the contenders, and we're a great time. Our company's real excited about right now, because we believe it'll be a chance for us to do much better in this environment, and we've done pretty well. We do have an advantage. We offer a money-back guarantee, results absolutely guaranteed, or you get your full money back. We're the only company in the country that does this, and we leave it completely up to the organization. So even if you win the Baldrige, even if you get every award and achieve every desired goal, at the end of that agreement, if you want any part of your money up to the full amount, we will give it back. Now, we've been around quite a while, and that's happened 2 times in our entire career. Both times is when a CEO change came immediately almost after we started, and then you have a CEO that might come in with a little bit of a different philosophy. What I'm going to talk to about, and I like this word, transparency. And I've learned in transparency, I used to have a slide years ago, and it said transparency creates accountability. And I've also believed that we go 2 ways with transparency. It either creates a great accountability or great rationalization. It depends on where we want to go. When we travel the country, almost any organization can have a group of characteristics that they can say ceases them from being successful. When we started working in Miami on how to improve patient care and patients' perception of care, they told us the reason they couldn't have good patient perception of care in Delray, Florida, outside of Miami, was there were too many New Yorkers that had moved into that area. Another hospital told us the reason they couldn't have good care is because they had too many non-English speaking patients. But we did a study of what did the non-English speaking, non-English understanding patients, how did they rate their care compared to the English speaking and English understanding patients? We found out the non-English speaking actually thought their care was better. I believe that's because they thought all the communication at the nurse's station was based on clinical outcomes that they were hearing at night. So sometimes we can come up with a different reason for different thoughts. So let me walk you through what I'm going to talk about. It's going to be called execution. I'm going to give you a couple diagnostic tools, and then we're going to walk you through, and I'm going to give you some things that are absolutely not in my book, because we're a moving organization. We have 160 full-time employees. 550 days every month we're in the field, including myself. So we're out in the field all the time. We come from operations. We don't come from anywhere else, but we've had to live in the day-to-day world of operations. We've had to live in worlds where you got 60 or 50 direct reports. Your life is making sure you have the schedule in place. Everybody's showing up. Everybody's doing what they're doing. My favorite quote lately is, "Vision without execution is hallucination." Because it seems like in healthcare, whenever we don't execute, we want to go back and do another vision statement, do another mission exercise, and just study it and plan it a little bit more. I have a free website and for the next 30 days. When I speak, I'm going to bring up tools and techniques that if you go to our website, you would have to buy them. That means that our partner organizations, if you're a partner organization, it means that you have an agreement with us. And if you have an agreement with us, you get access to all our information on the website. However, many of you are not part of our partner organizations. I bring up tools and techniques, and I don't want you to go to our website and say, "That son of a gun, he's a bait and switch guy. He got me excited. I went to his website, and he wants to make $39 or $79 or $15, or for some of these tools, $5,100. So for the next 30 days, you can go to that website and you can download every single thing on our website for partners. I'm not concerned you're going to do it because, again, execution is one of the challenges in healthcare. This is called evidence-based leadership. Some years ago, I was speaking on quality at the MGMA, and I was listening to physicians talk about evidence-based medicine. My thought was with evidence-based medicine, as they talked about standardizing better medical care, that we're going to frustrate the heck out of physicians, because we can standardize evidence-based medical care all we want, but if we don't have the systems that go around it, we just frustrate them. We're working with the Cleveland Clinic over improving their OR times. They did a study. 41% of the times that their OR started late, it's because the patient was there, ready to be cut, and the surgeon was not. 39% of the time, the surgeon was there and the patient was not. Now, when you ask the hospital what's wrong with surgery, they're going to tell you the doctors come late to the case. When you talk to the doctors, they say, "Why should we get there on time? Because the patient's not ready." So what I bring that up is, how do we align evidence-based leadership with evidence-based medicine? When we signed our agreement with Kaiser Permanente, they sent 200 physicians to my 2-day seminar. I do one every month. I called them hostages. They were told to come listen to me for 2 days. They didn't know where they were going, why they were going, because it was a contract we signed late. I was in LA, and they said, "Let's take advantage of it." One of the surgeons from Kaiser came up to me after the first break and said, "I get this now. It's called clipping instead of shaving." He said, "I used to always shave my patients, but today I have them clipped because there's less infections." When we see good research and good evidence, we change our clinical practices to get a better clinical outcome. We have taken that same technique and we call it evidence-based leadership. When you can see the research and the data, you see the outcome, how can you not execute? As a physician, once you see the data, you know that you're going to align your behavior if you've taken any type of oath. You cannot. Now, unfortunately, in leadership, we struggle with this more than I find physicians. Let me give you an example. I have research that shows that the lower employee turnover, the lower the mortality index, acuity adjusted. Which means the lower employee turnover you have, the more likely it is that people are going to get better clinical outcomes. I can show you absolute documentation. I spoke recently to a large healthcare system that's got 4 regions. One of the regions was implementing what we recommend, and their turnover was much less than the other regions. Their mortality was much lower than the other regions. So I said to the leaders of the other regions, we know exactly what you can do to lower turnover. And it doesn't have anything to do with money or benefits for this conversation. There's specific behavior that we can implement, yet you're not implementing it. That means that you prefer to have more people die in your region than implement evidence-based leadership. I call that leadership malpractice today. Because no longer can we act like these are anecdotal, sound good, cute story. Gee, let's read again about Southwest Airlines or somebody else. Now we have research that can show exactly when you do certain leadership tools and techniques, you will get better clinical outcomes. And that's probably why we're all here. Let me walk you through evidence-based leadership as we've developed it. We find there's 3 main functions of evidence-based leadership. Now, what we spend most of our time in healthcare talking about is aligning processes. That's what we do. We don't have any shortness of aligning processes. How many of you have ever been through CQI and TQM from 1990 to 1995? You can go anywhere and you weren't doing fish charts. We were doing CQM and TQI and all the stuff because it was going to work. I did. Today we call it Six Sigma and Lean. Why will this be any different? And it's not TQI, CQM, Six Sigma, and Lean. In fact, if you go on most Lean blog sites, they comment on my material all the time. The problem isn't standardizing. The problem is execution. We know the process. If you look at electronic medical record, you know, we're going to put all this money in electronic medical record, and I believe electronic medical records improve clinical quality of care. But let's not do what they did with the first bunch of money and misuse it and not execute it well, so we didn't get the result we were planning on getting. What's going to make us any different than the banks when they got their money? It's going to be called, can we execute or can't we? Most healthcare projects come in late, over budget, and don't achieve their desired results. So our problem is usually not what to standardize, and software are acceleration tools, by the way. Software is basically an acceleration tool to help things move quicker and faster. Now, please listen to what I'm saying. I'm not saying I don't believe in standardizing and aligning processes. I do. I don't think that's the issue in execution. I think we know exactly, like you said, what to do. When we do it, we're going to get better results. So let's move forward. In order to align processes, we have to align behavior, because that's really what it comes down to. We know if we round every hour and we talk about pain, potty, and positioning, the patient will fall less. We'll reduce falls 50%. We know if we make a phone call to a patient before an appointment, no-shows will drop 70%. We know if we make a discharge phone call and describe somebody's medications, side effects, before they go, once they get home, that we will reduce readmissions to the hospital within 72 hours by 33%. So we literally know the behavior we need to align. So now we're talking about how do we align behavior, and I'm going to go over this with you today. But see, there's a problem between aligning behavior and aligning processes, and I call that the performance gap. When you leave here today, I'm going to walk you through one of the reasons why most initiatives fail. We don't fire enough people in healthcare. We don't talk about that. It's like, oh, but we're in healthcare. We're here not to give up on people. We're here to do whatever we can to be successful. If they fail, it's my fault. I talked to a lady one time. I said, you ever talk to your low performer? She said, I did. I said, what happened? She said, she convinced me that I'm the problem. We don't fire enough people in healthcare. And because we don't fire enough people in healthcare, we allow non-compliance. What we permit, we promote. We will never be excellent until we stop permitting poor performance in healthcare. How many of you have ever inherited in your job somebody that is not meeting performance expectations? You ever notice when we inherit them and somebody complains about them, we tell everybody, we didn't hire them. They were here when we got here. Oh my God, it's the union. They won't let us fire these people, you know. That's not true. Or, you know who we really blame? Human resources. Human resources. Let me give you some statistics. When we look at healthcare around the country, and we do a lot of research, the average supervisor in healthcare supervises 20.8 people. Don't get caught up in the number. Get caught up in these two numbers. The average one says they have 1.7 people that are not meeting performance expectations, and 0.6 has any documentation. There's 60% of the non-performers in healthcare that we are just allowing to take care of people, and we're allowing them to impact employees in a negative way. They suck the life out of their coworkers, and we're allowing them to do it. I'm going to go over how to fire people before you leave. When I walk out of here, I hope you're highly motivated to do that. So now we're going to move to aligning goals. I'm moving to aligning goals, and I'm going to spend most of my time in aligning goals, because I think we have a real issue in healthcare is, number one, we're not good at alignment. Oh, we align on the mission, we sign standards of behavior, we do the values, we align all those types of good-feeling things. But I'm going to talk about real execution, and then I'm going to talk about training of leaders. Now, if you look at this overhead, you'll see points. We have developed the first system to evaluate execution. So this is a 100-point system. Now, thank you notes, which get a lot of play in my books, are 2 points. Which means you can write a ton of thank you notes and people feel thanked, but they still don't execute. Okay? Where we put most of our points is up front. Do you have the right evaluation system, and do you have the right training? Most of you have degrees in healthcare administration, but that's not true of the people you're going to lead. 98% of supervisors or managers or directors in healthcare have no bachelor's or no advanced degree in healthcare administration. Most of them got into healthcare to be a medical technologist. They went in to be a nurse. They went in to be an accountant. And they became leaders. And you know how most of us become leaders in healthcare? Our boss quit. When our boss quit on the way out the door, somebody said, oh my God, who's going to take your place, Lance? And you threw somebody under the bus. I bring them in and I say, can you be a leader? And of course, they might accept it. And it makes no sense. Most of these people went from an hourly employee to a salaried employee. Why would you do that? My daughter-in-law is a nurse. She works 7 p.m. to 7 a.m. If she works 72 hours every 2 weeks, she gets paid for 80. When I call her up, I say, when do you work again, Danelle? She goes, I'm off till 7 p.m. on Thursday. She doesn't reposition people in their beds when she's home. She doesn't do free blood pressure checks. She's off. She gets her schedule 6 weeks in advance. If she shows up 7 minutes too early, they tell her not to because it messes up the automatic payroll system. If she stays 7 minutes too late, they tell her not to because it messes up the payroll system. If she has a family outing coming and they ask her to work, she says no, no guilt, no shame, no remorse. That's the deal. That's what an hourly employee's life is like. So why would you trade an hourly employee's life for a leadership job? I think it's because we have no idea what we're getting into sometimes. But there's also a tremendous desire to have a bigger impact, The reality is we're now going to ask you to work more hours, less pay per hours, and work when we tell you when to work. When an hourly employee goes on vacation, they're gone. You don't even know how to get a hold of them. When we go on vacation, we are so sick, we tell people where we're going. We even say, no, I'm going on a cruise, but I bought an international phone, and we're docking at an internet cafe. I will send you an email if you need anything. So what we're going to talk about is most people don't have the skills to be a leader. In my book, I say you can tell the value of an organization and how much time they put into training managers. Because how can we expect people to do heavy lifting with a constantly changing environment if we're not constantly adjusting their skill set to survive? Which means because we don't do that, we lower the bar too much in healthcare. This is called evidence-based leadership. We go in and we help assess execution. Now, you're going to see points under our blue things, but you can put your own blue things under aligning behavior. The blue under the other stuff sticks, but on the other blue things, you can put, and this works for electronic medical record. If you're going to put an electronic medical record, you're doing so because you want to improve clinical outcomes and you want to lower your cost of getting those clinical outcomes. But if you don't put that in the person's evaluation, it won't stick. Most of the time, when we do initiatives, we don't change the evaluation process. Let me walk you through, we do research on why organizations don't achieve results. Because why do we think we're going to be any different now than we are before? Just because you have a lot of money doesn't mean we're going to be successful. Why should this be any different than any before? And by the way, don't think our employees are saying, oh my gosh, there's a change effort going on here in healthcare. They heard it during the BBA. They heard it through managed care. They've heard it through capitation. They've heard it through integrated care, non-integrated care, fragmented care. The beauty, if you stay around long enough in healthcare as a president of a hospital, you get credit for implementing something, you get credit for getting rid of it, and you get credit for putting it back in. It's a beautiful thing if you can stay long enough. Couple quick tips here. Number one, I believe it's entirely with the speakers that we get here on purpose. We did a study of healthcare employees. We asked them, when was the last time their supervisor shared with them a story, a letter, or an example of something their organization does to make a difference in people's lives? And only 1% said, my manager has shared something in the last 90 days. If we don't connect our employees back to purpose, we miss our great advantage in healthcare. If you're taking notes, high performers take notes, by the way. It's 3 compliments to every 1 criticism, according to Gallup. If you want to have somebody feel better about you, you better give them 3 compliments to every 1 criticism. We have built an entire culture in healthcare on negativity. Why? Because that's how we are. We're trained to notice symptoms, disease, illness, and injury. That's what we're trained to do, and I'm glad we are. If I go to the doctor because something's wrong with me, I don't want the doctor to say, Quint, I don't want to deal with that type of stuff today. Let's talk about what's not bothering you, okay? How many of you have ever picked up the phone where you work, called facilities and engineering and said, temperature's good? How many of you in pharmacy has ever called a physician and said, nice job ordering? It just doesn't happen. It takes 3 to 1. 2 to 1 is neutral, 1 to 1 to negative. We have a lot of material. Number 2, we don't get the critical mass because we want to do little things here, revenue cycle, we're going to improve this. You've got to create a system, as you said, based on any type of structure you want to get the critical mass. It's the tipping point we don't get. Next, we don't have a good accountability system. I'm going to go over that. We don't train leaders. We don't train leaders. What do leaders need to be trained on? Some basic stuff. Number 1, how do I understand financials? Number 2, how do I give a tough answer without blaming somebody else? Because we have untrained leaders in healthcare, we create we-they cultures throughout the organization. It goes something like this. Sam, if it was up to me, I'd give you that staff member, but you know, it's not up to me. I don't control the budgets here, you know what I mean? That's done out of Oakland, okay? That's something I don't do, okay? What we call it is we-they, and that's where managers, to answer a tough question, throw somebody else under the bus. They usually throw their boss or corporate under the bus. Then people don't want to move. Number 5, too many new behaviors introduced at once. According to research, if we try 1 behavioral change, there's a 93% chance of success, according to Franklin Covey. If we do 2, there's a 50% chance, 3 a 26% chance, 4 a 14% chance, 5 an 8% chance. We come in with a new idea, new program, we put the fire hose up to somebody's mouth, turns on the water, and wonder why they didn't drink any of it. We have to sequence. When most organizations we work with try this on their own, then they call us in. If you never want to work with us, get the evaluation system right, get the training right, sequence it slower, and fire more people. Because that's the 4 areas that we usually come in and help with. There's no process to recruit high, middle, and low performers. I'm going to go over that with you. There's an inability to take best practices. I can go in an organization and find unbelievable best practice. If you own at Blue Cross, I'm sure you can find places that do it great. The question is, how do we move it across? The ego gets in the way. I can take a goal from one organization and move it to another organization easier than I can down the hallway. or up the stairs. We don't move best practices in healthcare near as good as we'd like to, and we don't do it always. When you ask people, are you doing that in healthcare, they say, I'm doing it. But are we doing it always? We know, for example, according to our research, if you just want to improve patients' perception of care, it's dependent on did the nurse manager visit them while they're in the hospital. That's all you do. If you just have the manager visit every patient in the hospital every day, the patient's likelihood of recommending goes up through the roof. We know that if you want to have somebody feel good about home care instructions, if they get a discharge phone call, they'll go up to the 98th percentile, will say, I understand my home care instructions. If they don't get a phone call, it's below the 40th percentile. So the question is, do we do it? Never, sometimes, usually, or always. Let me show you something new that's not on your overhead, because I threw it in after getting sort of talking to people in the last couple days. This is an Indiana hospital system. It's one of the top 5 rated academic medical centers in the United States, according to the UHC. It's the 2nd biggest medical school in the country, and you would consider it a very successful organization. Most of our work is with organizations that are already pretty good, but they always want to get better. When Fred Lupa of Cleveland Clinic called us, I said, you're already pretty good, Dr. Lupa. He said, we want the gap between us and Mayo to be much bigger. That was his whole thought. He thinks there's 3 healthcare systems in the world, Johns Hopkins, Cleveland Clinic, and Mayo. And that's how he thinks on a regular basis. We did this. This is an external assessment, and you can do this. You would do it on a Zoomerang. In fact, if you want, we'll do it for free for you. We'll do it for free for you. This is basically what is your role. Now, right away, this CEO knows he's got a problem because he asked 917 leaders to fill out a survey, and only 557 filled it out. 300-something people have already said, I don't think so. In healthcare, we've created cultures of optionality. And in order to be great, you have to create cultures of mandatory. Some people say, Quinn, I don't like to mandate anything. I said, okay, then just make it required. There are certain times when you have to mandate. And if I work for you and I ask you to do something, unless it's illegal, unethical, or immoral, I expect you to do it. And if people aren't doing this, then they're probably not going to round. They're probably not going to do everything that we look at. But don't get hung up in that. Let's look at the results. Over the past 5 years, the external market in your area has been, do the survey and you're going to be shocked. Because what we're all talking about is how to create change. But the person that's going to create change is going to be the frontline supervisor. It's going to be the department manager. It's going to be the employee. We've been trying to do this at the top for a long time. It's how well, as you said, Dr. Scher, how do you persuade? And you got to know if people are willing to be persuaded. If I don't think there's a problem, I'm probably not willing to be persuaded. If you tell me to do a behavior that I'm not doing, I'm probably not doing it for a reason. If you can't persuade me there's a better reason for me to do it, I probably won't. 92% of the people will change their behavior on reward and recognition. What's being rewarded and recognized? And the reason is we don't use that enough in healthcare. So if we reward and recognize publicly, 92% of the employees will move to be what's being rewarded and recognized. If I sat here and I said, gee, I noticed, Lance, that today when you read the doctor's report orders right back to them and repeated them, that's excellent. That improves the quality of care. And 3 people hear me complimenting Lance on it, those 3 will start doing what Lance is doing. 92% will do what's being rewarded and recognized. Are you aggressively recognizing and rewarding the performance you're looking for in front of other people? 8%, the pain of not doing it has to be worse than the pain of doing it. They're only going to move when the pain gets hard enough that they have no choice. If you want to see an example of this, watch the A&E show called Intervention. Okay, so in the past 5 years, what's going on in the external market? Now, as you can see, everybody sort of thinks it looked the same. Look at normal, difficult, very difficult, so on, all over the board, which meant people didn't see it the same. I live in Pensacola Beach, Florida. It's an island. In 2004, Hurricane Ivan came through our island and 22 people were killed. They were drowned. You know why? Because even though everybody said a hurricane was coming, people looked at it differently. Some people didn't even leave for a mandatory evacuation. They stayed and they died. When Hurricane Dennis came, the entire place evacuated immediately. Why? They all saw the external environment the same way. We think our employees see it the same way we do. They don't. Because if we're in the top of the organization, we're seeing it much differently. We're reading everything financially. We're reading the healthcare reform. But you know what? That manager in our organization saying, is all the staff coming in that's supposed to come in? Who called in sick today that I have to fill their spot? The next question we asked is, over the next 5 years, how will the healthcare market be? Now, this is what started blowing the CEO away. Look at this. 48%, every single senior leader thought it was going to be difficult or very difficult. But now you start moving down a little bit. At the manager level, you had almost 70 people that thought it's going to be normal, easy, or very easy. Depending on how many people that report to them, you have now got a misalignment in your organization. Until you can get the people seeing the external environment more the same, it's going to be harder to get them to adjust behavior. They will, but it's going to be harder. Here's the scary one. If we continue to perform exactly as we do today, basically our results will be 321 managers said if we stay exactly the same, we're either going to get the same results, better, or much better. Now, that is not an isolated incident. We do this around the country before we start any agreement, and what we have is the first great disconnect of alignment, that the managers see the environment much different than the top leaders. We asked a few more questions. How well does your current evaluation system hold people accountable? We find in healthcare most feel it does not. If you want to ask yourself a question, here's a real quick down and dirty evaluation system. Is it possible for people in your organization to get a good evaluation even though they don't perform well? What do you think? I'll even give you a way to test that by the time you leave. If the answer is yes, you can do all you want on all the other stuff. But you know, if you put lean in like you're putting in, right? You put lean in and you tell me I need to get certain results, and at the end of the year, I don't get the results, Wendy, and I still get a good evaluation, and I didn't really feel good about lean, guess what I quit doing? Lean. The reason we have good results year one is because the leaders don't know if they're really going to be held accountable. That's why we end up usually having good results that slowly erode, and then we have to look for the next buzzword, the next case study, the next thing that we can put in play. Does your current training train you? The answer is usually no. In fact, sometimes they have to say, can you remind me what training I'm evaluating here? Because when we get into trouble, the first thing we cut is education and training. In fact, the next thing we cut is travel. That's sort of an interesting thing. We're all sitting here losing money, but we're afraid to let anybody learn how to get any better. Yep, we're not traveling anywhere. We're going to stay just as stupid as we are right now. So the first thing we cut out is ways to get better. It just doesn't make a lot of sense. How many employees do you supervise? This is 16, but remember, it's an academic medical center, so you have a lot of researchers. Non-academic is about 20.8. How many employees do you supervise would you not rehire or aren't meeting performances? They said 1. That means they have 596 people that shouldn't be working there anymore that are working. That's an anchor. Do you have an anchor? Because if you have an anchor and you don't deal with your anchor, you're never going to get the sailing that you're going to want, and eventually the rest of your organization will burn out. There's nothing worse than an employee coming to work, working with a coworker that sucks the life out of them each and every day. You know why most of us get tired of leadership? It's the low performer that wears on us. You ever have a low performer quit? Isn't that a good feeling? Oh, I can't believe it. You don't need 2 weeks' notice. Go now, go now. Less low performers are going to quit because they can't sell their house right now. So you're going to be stuck with more performance issues in the future. Of course, do we document them? The answer is once again no. Over 50% of performance issues in healthcare are undocumented performance issues. I bring this up because if we don't deal with some of the root causes of issues, we're going to continue to deal with symptoms. Symptoms are medication errors, they're falls, they're poor documentation, they're not good clinical care, because we always think we can change, we can't change. In my book, Results at Last, my favorite sentence is in the first page. It says, I'm tired of reading about books that tell leaders to get everybody on board. We set people up for failure. There are certain people you will never get on board. But we get you thinking, if you don't, it's your failure. It's not. I know who your low performers are. I can find them out. How many of you right now supervise more than 20 people directly? Okay. Do you have a significant other? And name? Excuse me? Excuse me? I can't hear one. Taj? If I call Taj right now, they can tell me who your low performers are. I guarantee it. Has anybody ever here talked with a non-healthcare person about their low performers? When we start telling non-healthcare people about our low performers, what do they tell us to do? Fire them. And what do we say? We can't. We're in healthcare. We're here to rescue all our people. One day I got a call in New Orleans, a nurse manager said, Quint, what do you do with a nurse that has a bad attitude? No one wants to work with her, but she's a good clinician. I said, you fire her. You're not here to run a rehabilitation center for wayward employees. She is sucking the life out of the other people. Now, I don't mean you just go up and do it. I'll talk about there's easy ways to find this out, but I know it's uncomfortable. But you know what's even more uncomfortable? It's the 92% of the employees that go home and wish they had a better leader. So 92% of the employees that go home and say, I wish my boss held everybody to the right agreement, the right expectations, and they consider it unfair. So we'll talk about that before I leave. From a patient's perspective, how would you rank your organization? It's always good to know how do the leaders feel in it? Because the leaders don't feel pretty good about it. We got challenges. Rate the skill set of the organization in implementing best practices. And this is a good organization. Yet they know that they still struggle because they have 8 or 9 hospitals in their system. And of course, if this one's doing it, gosh forbid, I'm going to do it. I call that the testosterone effect of healthcare. Okay, there's an ego that gets into play that I won't follow anyone else. When we have to put that down, physicians are better at this than non-physicians. When physicians see somebody doing something that works, they want to find out, tell me what you're doing. In healthcare leadership, non-physicians sometimes don't want to follow the leader. Good leaders even know when to follow other leaders. As a physician, rate the ease of practicing medicine, and you can see where we're at. So I bring that up because it's an assessment tool that you might want to use. As a non-physician, rate the consistency of leadership. Because what do you really want in our organizations? The patient has the right care no matter where they enter it. The physician has the right experience, practice of medicine no matter where they practice it. The leader has the right ability to lead, the right training no matter where they lead. Okay? And the employee has a good leader no matter where they work. By the way, the number one reason why people quit their job in healthcare has nothing to do with job, it has everything to do with leader. People don't quit their job, they quit their leader. So now let me go through the presentation, and I'm going to hit 2 points. One is objective evaluation system, or what we call accountability. This is Medical University of South Carolina. This is what they looked like in '06. Don't get hung up on the numbers, get hung up in the faces, because this is how they judge performance. They had 9 critical factors for success. Out of those 9, they hit 1 out of 9. Doesn't mean they were bad. If you look at their mortality was still quite good, but they didn't achieve goal. Now you look, if you're sitting here and you're looking at an organization that didn't achieve goals, what do you think the evaluation performance would look like? Oh, by the way, they used the usual dramatic healthcare evaluation system, substantially exceeds, meets, and we don't even want to put does not meet because it sounds nasty, so we put needs improvement, okay? Okay, and it's all subjective many times, by the way. It's usually a subjective evaluation system. So they had 900 leaders. Let me show you how they were evaluated. These were the results. These were their evaluations. 73% were told they substantially exceeded expectations. If you want to have some fun when you leave here, go to your human resource departments, have them track your results, and then show you how the employees fell and the leaders fell in the evaluation process. We over-evaluate people in healthcare. You can't be better than your results. You can't be better than your results. If you get average results, you're an average leader. And in healthcare, we overrate people's results. So let me show you the next year. This is the next year, and that's actually not goals, that's results. And as you can see, they improved up significantly in every area. The only area they went down in was in the red, and that's because their turnover went up. They would tell you the reason their turnover went up is because they dealt with some issues in order to get the other performance metrics. If you write me an email, I'll even tell you how to hold people accountable for reducing turnover and getting rid of more people at the same time. And my email is quint@studergroup.com. This is an example of Downers Grove, Good Samaritan, one of the most clinically outstanding hospitals in the United States. What they did is they told their director, or their manager in the ICU, that 75% of your evaluation is based on clinical performance. If you're a medical director here, go to managers who you're hoping get better clinical outcomes and see if clinical outcomes are even in their evaluation system. Many times they're not. So what they did is they decided they wanted to focus in on decreased ventilator-associated pneumonias. And they wanted to also improve and reduce ventilator days. Now what they did is they put it in the evaluation system. So this manager knows that 75% of their evaluation was based on improving these two clinical outcomes. Doesn't mean the other things aren't important, but most leaders want three things. Tell me exactly what you want me to accomplish. By the way, here's a tip. If you want to know this question when you go home, make an appointment to see your boss and ask this question. If 1 year from now I've exceeded your expectations, tell me exactly what I would have accomplished. Don't be surprised if your boss says, excellent question. Good thinking. Let me get back to you. Especially if it's an objective format, not subjective. The second thing they want is priorities. By weighting the evaluation system, you drive them to where you want them to focus. Because most people will always go to what's comfortable, but it doesn't mean it's what's important. And the third thing everybody wants is training. Give me training to be successful. And that's usually what we find is missing in healthcare. Now, these were the results, and these are the goals. And let me walk you through the results once they changed the eval system. Once they changed the eval system, central line infection rate went way down. And if you want to look up their numbers in an IHI, they're an IHA laboratory right now, and you will see that their numbers have exceeded to get better and better and better. Their vent days went down, and their ventilator-associated pneumonia went way down. Now, we always like to put financial impact into everything we do. So we did a financial impact that showed this was over a $900,000 cost savings to this unit. In today's environment where I got to cut cost, I'd rather cut central line infections and ventilator days to give me the cost than cut staff out of the hospital, than cut training out of the hospital, than cut travel out of the organization. But see, we do those other cuts because we can't execute some of the cuts that we really need, some of the improvements we need to execute. Now I'm going to close today, my portion, with the performance gap. And this is just a little spotlight, but this is what we find. If people ask me, Quint, if you never do another thing in healthcare, what's the three biggest accomplishments you feel you've been involved in? One is the formation of evidence-based leadership. The slide I showed you in the execution system. Number two is something called AIDIT. It's a technique to reduce anxiety in patients and increase patient compliance. And the third one is this one right here. How come we've had program after program? You know, when you come to your hospital staff and you say you got a new program, a new buzzword, you even mention my name, the first thought is, oh my God, make me gag. Not another one of those people. Give me the pin, give me the buzz, give me the pizza, give me the t-shirt, and call me in 3 years. Most healthcare initiatives of change process last 3 years. When, according to John Cotter, it takes 10 to 12 to get to success. According to us, it takes 3 to 4 to where you got it hardwired. According to James Collins, it's 5 to 7. But we never get to the outcome because we stop on the journey because we hit a wall. It's like running a 26-mile marathon We get to the 20th mile, we hit the wall, and we stop. So what is the wall in healthcare and performance? And let me walk you through what we have learned. We've studied over 350,000 employees in 2005. We developed this in 2001 and have now been doing it for over 8 years. We have a lot of research. It's called HML, high, middle, low, before we do it and after. We also look at organizations and ask them, based on your using this now, are you better with high, middle, and low? And you can see significant improvement once they implement this tool or techniques on execution. We found out 34% of healthcare employees would be considered a high performer. Most of you are high performers. Number one, you didn't go home after lunch, or you didn't go back to work. Number two, you're taking notes. Number three, you're paying attention. Those are high performing attributes. Middle performers, so high performers are solution people. High performer love achievement. High performers will sacrifice for the betterment of the organization because what turns them on is hitting desired outcomes and achievement. If a high performer works for you, they don't beep you, text you, or bug you while you're here today. High performers are solution-driven people. That's a high performer. Middle performers are problem identifiers. Middle performers tell you there's a problem. And many times this is just because they don't have the experience or the self-confidence. If you want to develop middle performers, when one of them comes up to you and gives you a problem, you just say, tell me what you think we should do. Most middle performers absolutely know the answer, but they don't have the self-confidence yet to provide it. That's a middle performer. 8% are low performers. Your low performers find something wrong with everything. If you have low performers and they knew you were going to be gone today, they drag their butt to work no matter what, because they are not going to be sick on a day when you're not going to be there. Okay? If you want to find out low performers, just give them all free food. Low performers will even complain about free stuff. Just give them free food. When they complain, just fire them. Okay? Low performers find something wrong with anything and everybody. And there's only 8% of them, so you can say, well, how do they get so much power? Well, here's how they get it. They mess with the middle performer. The only weakness high performers have is they're so focused on their own achievement, they don't mentor and they don't help other people because they're focused on their own performance. The only way a high performer will help somebody else is if you ask them to do it and tell them to do it, because it just doesn't come naturally sometimes because they're focused on their own performance. I own a minor league baseball team. My high performers are in the batting cage working on their own hitting. They're not worried about anybody else on the team unless I ask them to go over and can they help somebody, because high performers are so focused on their achievement. That's why an evaluation system will hone them into better teamwork. So we all work with the middle performer. And the low performer has to get the middle performer with them. You present a better system, a better technique, a better plan, healthcare reform. I don't care what it is, here's what's going to happen. Your high performers are going to learn a new technique, a new achievement, a new tool, and they'll go do it. Give me your high performers, we'll teach them better patient communication, they'll do it the next moment. Give me your high-performing leaders, we'll teach them how to engage by rounding on employees better, they will do it immediately. High performers move quickly. Middle performers watch the high performers, and they look at the better doctor, and they will then follow that technique because they see what's being rewarded and recognized. Now, about this time, which is anywhere between 6 months and a year of any type of change process, the low performer doesn't change. The low performer doesn't change because they don't plan on it. They've outlasted every change, every process, every technique, every tool, and every leader. They look at you and laugh because you're the fourth leader they've had. They are not afraid of crucial conversations. You can bring that book with you wherever you go. It does not intimidate them. They've had crucial conversations in 3rd grade, 8th grade, high school, their first couple marriages, and their current neighbor is involved in a crucial conversation. They are not afraid of you. They will outlast you. The gap is uncomfortable, but we don't move quickly. How many of you have ever fired anybody? Have you next day said, you know what, I probably rushed it a little too much? By the time we fire somebody, we're exhausted. We're at the EAP, okay? When we go to do it. We're hoping more time will help. That we're hoping that maybe more training will help. We're hoping that if we focus a little more on this low performer, we're hoping maybe they'll transfer, or maybe they'll even quit. Low performers act like they're going to quit. Low performers announce their retirement years before they're really going to retire, because their whole goal is to get you off my back. So what happens? We go out between a year and 2 years and we hit a wall. We hit a wall and the high performers are tired, they're discouraged, and they're disappointed because they work so hard and they still see that low performer sitting there. The middle performer is even more exhausted because this didn't come as easy and as naturally to them. So you got 92% of your team that's exhausted, tired, and discouraged, but don't worry, you got 8% of your people that are feeling just fine. Your low performers are just fine because they have not changed the behavior whatsoever. So what happens is we hit the wall and we start moving down. All of a sudden the CEO says, you know, that was really working well for a while, but it doesn't work well now. Maybe we just got to change it. Let's look for the new buzzword, the new color, the new t-shirt, the new speaker, the new tape, the new book. And that's not the answer. We did research. You know what the answer is? You got to fire some of these low performers. If you don't fire these low performers, you're just going to repeat the same behavior every 3 years over and over and over again. So how do we get over this wall? Let me close by walking you over the wall. Number one thing is we have to meet with our high performers. Now, if you have a low performer that's toxic, deal with them. If you have a low performer you've documented on, deal with them. But you probably haven't, because 60% of low performers have no documentation. Meet with your high performers and get your high performers to stick with you during this process. Tell your high performers where the organization is going. High performers want to be on the winning team. Tell them why they're important, and high performers hate general compliments. You want to tick off a high performer, just say, I just want to tell everybody here what a great job you're doing. You say, you don't know what the hell you're talking about. Bobby didn't show up for 3 days here now. Bingo. If you glad hand a high performer, they lose respect for you. So you want to tell them exactly why you're having this conversation, go through their good qualities and why they're so important, and then ask them what you can do for them. They're going to ask for one of 3 things. They're going to ask for more opportunity, more responsibility, or more training. Then move to your middle performer. When you move to your middle performer, they're different. The first thing you're going to tell them is you're having these conversations for professional development, and you want them to make sure that they stay. You hope that they stay with your department or your organization a long time. You reduce anxiety. You tell the middle performer all their good qualities, because they have many good qualities. What middle performers want different than high performers want more opportunity, more responsibility, more training. Middle performers want more training. Middle performers want more development. In fact, we did the largest study ever done on women and work-life blend. It's on our website. And do you know in healthcare, there's 2 things that women in healthcare want more than anything else? Give me a good boss. Because if my boss and I get along, they'll give me the flexibility and the understanding I need. The second thing they want is give me good training, because I want to be as effective and efficient as possible, so when I'm home, I'm not worried about work as much. It's called the Women and Work-Life Blend Study. We have a wonderful free webinar right now on our website if you want to see the results. So we pick one thing to coach on, only one, remember, because we want to be successful. And then we close with, remember, you're a good employee, you're a solid performer, we want you to stay, boom, boom, boom. Because we got to get them away from the low performer, because what we want to do is create that gap. Right now, your low performer's feeling isolated, they're feeling worried, they're being concerned. They're even starting to act out a little more, because this thing's getting away from them now. So now we're going to meet with the low performer. A couple tips. Practice with other people before you meet with that low performer. If you have not role-played this conversation, that low performer is going to eat you for lunch and spit you out. They will start getting you so off topic when you leave, you had no idea what went on, okay? Go to HR, be entirely honest. Tell them that you probably should have been dealing with this person before. You haven't done much documentation, but here's what I got. Tell me how far I can push this. And then you want to get ready, you want to practice, and when you got ready, you want to accomplish 5 things. Number 1, you want to describe the behavior you're observing, and when they interrupt you, you want to tell them, please let you speak. When you're done, you'll talk. We have lots on this on our website. Number 2, you want an E, they call it desk. You want to evaluate the procedure they broke, the policy they're not following, the standard behavior that they're not adhering to. So you want to be very specific. Numbers S, they're already now saying, no one taught me, no one showed me, I had no idea. You want to now say, I will show you exactly what the expectations are. And number K, you need to let them know the consequences. This is a verbal warning, this is a written warning. If it happens again, boom. Out of the 8% of your low performers, here's what's going to happen. 1/3 of them will actually move their performance up. You'll redeem their career in your organization, because if it's not permitted, they will not do it anymore. They will just move according to what's permitted. 1/3 of them will quit. 1/3 of them will find another place to go. You ever have an employee quit and go to a competitor, a low performer go to a competitor? You sort of thought you won twice that day? You really don't, because we're all in this thing in healthcare together. So 1/3 of them will quit on their own, and 1/3 of them you will probably have to fire. And the other 2/3 of the 8% will not move until they see somebody get fired, because they don't believe that this is actually going to happen. Because see, in our organization, we just don't hold people accountable. And then you need to follow up, because they're still not afraid, because they think that you're not going to follow up. So you got to walk through the follow-up technique. Because what are you talking about the whole morning? What are we talking about with healthcare reform? We're talking about moving performance up. Even though we're all here to talk about policy, I don't think our issue is policy. I think our issue is execution. I think if we executed better, we probably need less policies. But because we don't execute better, we always think we can somehow policy people into performance. Policy is important, education is important, but as Dr. Chartel says, it's can you get the results? Culture outperforms strategy every time. What culture is consistent behavior, and done together, it's absolutely unbeatable. Why become leaders? We become leaders to make a difference. Your employees take you home, your patients take you home. And each and every day, you have a huge impact. Most hospitals and most healthcare organizations are either the first, second largest employer in their area. 1 of every 12 people in the United States of America right now are employed in some form or fashion in healthcare. We create better organizations for people to work in. We create better organizations to give people care in. We create better patient care, better places to work. We create better communities. If we create a better community, we create a better world, and that's why we got in healthcare in the first place. Thank you very much. I appreciate it.